Hi everyone, this is Christina Ackerman, web editor for JEMS, welcoming you to today's webcast. It's about time, addressing the crisis in communications in healthcare and EMS. Today we're going to hear a case study from Colorado Springs about the steps they took to improve emergency communications in their community. And it's my pleasure to introduce our speakers for today. Dr. Stein Bronsky is the medical director for the Colorado Springs Fire Department in AMR in El Paso County. And James Woodson, MD, is the founder and CEO of Pulsara. And with that, James, I'll turn it over to you.
Great. Thank you, Christina. So we appreciate everybody joining us today. So what we'd like to do today is really take the time to describe what we believe is really an overlooked crisis in healthcare. And then we'll talk about how we solved this problem, how we're addressing this problem. And then Dr. Bronsky will join us, and we'll be talking about how he helped really operationalize an entire region to deploy this platform. And then he'll discuss some of the results that they're experiencing. So the first thing I like to do is really kind of set the stage of what problem are we trying to solve. A lot of times people will hear about Pulsara, or they'll be looking for a solution, and they are kind of looking with blinders on. They'll start thinking about ECG transmission, or others are just pre-hospital notifications, maybe converting an oral radio report over to an electronic pre-hospital notification. There are others that are focused just on their STEMI process of care, or others just on their stroke process of care. And really what we want to do is focus the problem on a couple of things. The first one is really communication. A lot of times we take communication for granted. We don't really dig into all the different components of communication, answering some sometimes hard questions, such as the who, what, when, where, why, how, and how much. A lot of times people start trying to add more and more on, and it gets unwieldy. Other times people don't really focus on the communication channel. So we have to transmit information across a bunch of noise. And a lot of times we choose the wrong communication channel. We'll be talking today a lot about mobile technology like iPhones and Android phones and tablets, etc., and how that might be a better channel than some of the archaic technology we use. The next thing that I really want to make sure that we're focused on is teams. So we really focus on building regional systems of care and communication in regional systems of care. So what we like to do is focus on being able to touch a button, flip a switch, and instantly build a team. So a team for something like a heart attack or stroke or other time-sensitive emergency, you need to be able to manage communication and logistics, not just during the pre-hospital space, but during the intra-facility or within the facility that's taking care of the patient, and sometimes transferring the patient. And so really when you look at the unique complexities of things like time-sensitive emergencies, you can have resources scattered across an entire city or an entire region, and every single day and every single patient during that day is going to have a different team. So the question that we're really trying to focus on is, well, how do we manage these teams? So I like to start by currently asking how and pointing out how we do it now. Before we dig into how we manage something like a heart attack, I like to answer or ask some specific questions. One is, for example, when's the last time you paged somebody and that person can't be in healthcare? Most of the time, we kind of look around the room and no, we don't really use pagers anymore. How about emergently fax a grocery list to your spouse? Well, no, we don't do that either. And then another one is, how many times do we pick up a handheld radio and call our spouse and let them know that we're coming home, we're coming in? We don't do that in the rest of society, and there's a reason why we don't do it. But with that as a kind of a backdrop, let's look at how we do communication for something like a STEMI case. So we'll go ahead and have the medic on scene. They've already done a 12 lead. They've identified a STEMI. What they do from there is they typically Bluetooth or get the ECG into an old-fashioned modem. They send it up to a receiving station. And then from there, we typically distribute it one of several ways. Either it goes to a fax machine, or there's a blinking computer over in the corner, or maybe there's a blast email that gets sent out, and people have to try to find the right ECG on that email. They also they can't track it because they can't use that knob thingamajigger on the monitor to get in the name. So after they get the ECG transmitted, they typically have to pick up an old-fashioned two-way radio. Sometimes they do it by phone, and they basically give an oral report to a nurse or somebody there at the hospital. And then once the hospital team starts to get mobilized, what they do is they typically send off a blast page, and so literally 10, 15 members, depending on what type of time-sensitive emergency it is, a page will go out. Then everyone has to stop what they're doing. They actually have to use their own personal cell phone and call an operator who has a list, and they're checking them off the list to see who knows what when. And then they basically patch together the rest of the communication with a hodgepodge of HIPAA-compliant, non-HIPAA-compliant messaging, tons and tons of phone calls, often where pagers are used, unit clerks, answering services, etc. And all this time, effort, and money we use to spend to get the ECG to the emergency department, we usually whip out our smartphone, take a picture, and text it to somebody anyway. And then what happens, if it's a transfer, you have to basically get all those same complexities we just described, but then try to get through a transfer center using all the same archaic technologies. We could go on and on by re-involving EMS into the process for that transport, but I think you get the idea of how many different archaic technologies we patch together, how many of those leverage the oral tradition, which when we say it, basically it just turns into vapor and goes away. It's not data that we can use thereafter. And so really one of the questions that we have after that is, well, is that a problem? This is kind of our reality check slide where we like to put things into perspective. It's not to minimize any of these conditions or anything like that, but I can't watch a football game without pink ribbons, can't fly Delta without pink ribbons, can't turn on the news without hearing something about the opioid epidemic. But each of these conditions, whether it's gun violence, vehicle crashes, breast cancer, the opioid epidemic, you're typically looking at 30,000 to 40,000 people a year that succumb to this disease or this tragedy. However, when we look at miscommunication and medical errors in healthcare, the numbers are pretty astounding. So estimates show anywhere from 250,000 to 400,000 people a year die from miscommunication, from medical errors. On top of that, there's another 10,000 serious medical complications every single day. And this is all because of miscommunication during transitions of care. So if we basically look at, well, why does that occur? Well, we put our teams in silos. So we give EMS, we give them modems and phones and radios, and then we end up giving the neurologist and cardiologist and our specialists, we give them pagers and phones. And then we expect the emergency department to kind of be the person that patches all these things together. And so basically we've created siloed teams, and our teams are siloed, especially when it comes to their communications, away from each other. So this really turned us a few years ago into really looking at modern platforms. How is it can we go onto any device that has connectivity and do something like Amazon that can bring together millions of buyers, millions of sellers, billions of products. With a tap, I can bring in reviews of those products. With another tap, I can bring in financial institutions, and that information is every bit as sensitive as our PHI in healthcare. Another tap, I can bring in logistics companies. So literally anywhere in the world with connectivity, I can with a couple of taps, see, evaluate, purchase, and watch my shoes delivered to my front door. Whereas in healthcare, we're patching together all of these archaic communication technologies. And so what we've built is a single version multi-tenant communication logistics platform. So what does that mean? Instead of a highly siloed program that you see or system that you see on the left, it's a single version. There's just one version of Pulsara. So the other component of that is multi-tenant. So what that means is I can add a team member with a tap of a button to surround a patient to stop a time-sensitive emergency. And so that is what Pulsara has built. A couple of key components to that is no longer are we kind of quarantined off by EMS agency or by hospital. We can cross those boundaries, so we can bring multiple EMS entities and multiple hospitals together on the same page to assist this patient. So the next thing is really this is one communication standard. We are there to help operationalize best practice standards to really simplify and standardize the protocols for time-sensitive emergencies, really regardless of time-sensitive emergency and regardless of method of arrival. And that's because we truly unite the pre-hospital, intra-facility, and inter-facility teams. So with that, we're gonna pause for just a second and watch a 3-minute video that's kind of a demo video of the Pulsara STEMI solution in action. If we could go ahead and roll that video.
A medic quickly starts a case by tapping New on the home screen. Then they tap on the STEMI module, select their destination facility, and enter their at-patient and scene departure times. Distance and ETA are auto-calculated using GPS. The medic can then enter the patient name and a few quick yet vital pieces of information. Adding a contact makes it possible to call a witness or family member directly from within the app, even after the case is complete. Save 1,000 words with a tap by adding a picture to the case. Images aren't limited to ECGs. A quick snap of a handwritten medication list or a driver's license is shared with the whole team in seconds. With another tap, the hospital immediately receives an alert. EMS is notified when the hospital acknowledges the new inbound case. The hospital is then able to see critical information about the patient, including the ECG. All team members, including EMS, can send HIPAA-compliant messages using customizable templates. At this time, if the hospital wishes to activate their STEMI system, they can select the on-call ED physician and cardiologist and tap Activate. All on-call team members and all assigned physicians are simultaneously notified. If your facility is like others, that trusted on-call list is constantly being updated, no problem. It is simple to reassign another physician to the case. When the cath lab is ready to receive the patient, they can notify all team members with a simple tap. Anybody can quickly add a message for the entire team with a couple of taps. The Stop STEMI module is divided up into logical window panes. The next 2 panes are for the emergency department and the cath lab. The ED can instantly notify the team when the patient has arrived by entering the door time. For accountability and transparency, all team members can see the uploaded images and who is on call. In the Teams section, members can see a summary of every person associated with the case, alerts they have acknowledged, and with a single tap, they can call them directly from within the app. Key metrics like door in, door out time, and activation to cath lab ready are automatically captured. In addition, our bar timers provide visual clues to each department regarding where they are in their current case with respect to their facility averages and facility benchmarks. And, of course, the ever-present universal clock keeps everybody synced. To stop a case, simply tap Stop STEMI. Now you can select the stop indication, and everybody, including EMS, is immediately notified. Now everybody can see a summary of the patient outcome.
Okay, it looks like the video has completed here, so I'd like to dig back in and also let everyone know that the demo videos of all of our different solutions within the platform are available at pulsara.com. So the The first thing I really want to point out from here is what we're not, which is a magic bullet. One of the things that used to frustrate me when I was on the receiving side of these is it made it sound like this was going to solve all of your problems that you have out there. And really one of the things that I'd like to highlight is we love to be the partners of these organizations. And this is what we'll get into talking with Dr. Bronsky here in a minute, because you really need to surround this platform with amazing processes, and this is really a tool and a new way of doing the job. What it does do is instead of trying to link together a bunch of silos with chains where we're doing kind of one-to-one communication or one-to-few, we've really built a neural network. So instead of sitting in STEMI meetings and stroke meetings, et cetera, what we like to do is basically in real time give the tools to identify when there's a breakdown in communication and the tools available to solve that problem in real time. So in essence, what we've built is a neural network or a shared consciousness where the strength of the system is truly greater than the sum of its parts. And so the results that we get, you can also find these results on our website at pulsara.com. You can see typically we're reducing everywhere we go STEMI and stroke treatment times between 10 and 46%. I'll let you guys dig into the studies there. We have some other studies that will be released here next week at the International Stroke Conference. So what we do now is we focus on end-to-end care for STEMI and stroke. We also can replace the radio report for all EMS patients, for all general patients. And so one of the other things that I'd like to highlight, and Dr. Bronsky will get into this a little bit, is when you start to operationalize this in a system, Dr. Bronsky will show one example where an entire region started all at one time. But there's also the ability to spin this up where it's led by EMS, other areas where it's led by the hospital end. We make all pre-hospital communication for free. So that radio report that's traditionally done, we're replacing that with an electronic pre-hospital notification, and that's done at no charge. Currently, that's at no. We've always had it at no charge to EMS, but we're also making that at no charge to the hospital. What we're trying to do is open up teams and regional systems of care. And so by giving this piece of the platform away for free, it allows us to go in and show how we can solve a much larger problem for the entire system, specifically all the complexities at the hospital level. We will be building out other time-sensitive emergency modules like trauma and sepsis, cardiac arrest, and others. We'll also be bringing more video components into this platform and moving towards more passive data collection and integration down the road. So the final thing I like to focus on is really the purpose of what we do. Our focus is to improve the lives of patients and caregivers through innovative communication. We feel very strongly here at Pulsara that if we focus on the providers, on the caregivers, that's the way that we can actually leverage technology where it's helpful to us as practicing clinicians and not just something that looks good on paper. And by focusing on these workflows of the clinicians, really truly uniting them, we believe that's the best path forward to using technology to improving patient care. So with that, I'd like to turn it over to Dr. Bronsky.
All right, thank you, Dr. Woodson. This is Stein Bronsky, and I'm the Chief Medical Director for Colorado Springs Fire Department and El Paso County AMR in Colorado. We are very lucky in Colorado Springs to have a fantastic medical community that was willing to take this on as a community-wide project for the betterment of patient care. And so I'm just going to go through a little a summary of the process that we went through and how and why we chose Pulsara and what has happened with that. Our community, just to give people a baseline of understanding, is Colorado Springs is about 450,000 people within the city limits, and about 675,000 actually in the surrounding metro area and county. We have 4 major hospitals that belong to 2 hospital systems. One of them is a university system, and we have over 50 feeding EMS agencies into all of those hospitals, many private and fire-based. We have approximately 60, I was putting that on the low end just to make sure I wasn't overestimating, but it was about 68,000 medical, solely medical 911 calls last year. And so we have the same problems that Dr. Woodson talked about with communication. I think they're universal. When you're dealing with a lot of different hospital systems, with multiples of agencies, with different technologies, and the communication between EMS and the hospitals, as well as the way that the hospitals communicate inside themselves, is to be desired. Sometimes there are little pathways that have made fantastic adjustments and have really made it very smooth, but in general, it's just like the slide that was shown earlier, where you have this one link in the chain that breaks, and then the whole system breaks down, and what ends up suffering is the patient. And so we decided as a community that we needed to create a uniform and seamless communication system that spans from curbside EMS to the hospitals all the way through definitive care, and then ideally would give all of that feedback downstream again to EMS for loop closure. That was a big task, and we saw that Pulsara was going to potentially offer and has offered what we think is a fantastic solution. We had many challenges, as I'm sure everybody who's listening in is thinking, well, we can't do that because of X, Y, and Z. I can guarantee you we had the same problems. We have multiple EMS agencies all under different control, all deciding how they were going to do what they were going to do. We had 4 different hospitals, and even though they only belong to 2 hospital systems, each hospital individually is very different, with different management, different service lines, and this all created very inefficient communication. There also was the challenge of who do you go to in the hospitals to present this and to get their buy-in, because every service line within the hospital is not the same. Cardiovascular service lines are different from the neurosciences, different from the trauma, and they all operate in their own silos. And one of the other big challenges we had was that there's obvious competition. The Centura Health System is one system we have out in Colorado Springs, and then the University of Colorado is the other one, and they are hugely competitive with each other. And so sometimes, as you can all imagine, it's difficult to get them to be on the same page because they can't get over the competitive aspect of patient care. And then there's just the holistic theme of change. Anytime you bring change into a situation, people are resistant. And so we had a lot of barriers to overcome. And where we decided to start on this was to get everybody around the table, and thankfully we had a forum to already do that that was guided by EMS, where we get all the hospitals to sit down together and all the service lines to sit down together and give us reports to EMS so that EMS could better figure out how to serve the community and where to deliver patients, etc. And so through that forum, we started to have discussions with both of the hospital systems to promote the idea of creating an environment of collaboration among all the different hospitals in our community for the betterment of the community and for betterment of patient care. And if we can get all of EMS and all of the hospitals on the same page with this, then we can, as a community, probably affect patient care better than any individual little project that's going on. And so we decided as a community that this was going to be an all or nothing event. We were either going to get everybody on board or scrap it. We wouldn't have actually scrapped it, but that was my original goal. It was my Hail Mary that I put out there and said, let's all sit down and talk about it. So first, the hospitals were difficult in some ways to talk to about this and easy in other ways, because the neuroscience lines would absolutely loved this idea, because their service line is more in an infancy than the cardiovascular service line. STEMI is very streamlined in a lot of communities, and they have a very, very fixed way of doing things, and they feel as though, if you're anything like our hospitals, they felt as though their system was near perfect, and they really weren't willing to sit down initially and talk to us about the fact that there might be something out there that can help with their efficiency. But the neuroscience lines were very different. They understood that they weren't as developed as cardiology, that they could benefit right out of the gates from this type of technology and communication from the field. And so our hook in our community was originally with the neuroscience lines. It was also important for us to go to the hospitals and say that the administration needed to have buy-in on this, because we felt as though we could not come from EMS and say, we want the hospitals to do this, and guess what? You get to pay the money for it because it's free to EMS. We had to sit down with the hospital administrations and make sure that they felt as though this was going to be a worthwhile concept to them, and that their return on investment would be something that they were willing to take on. Thankfully, after our initial discussions, both of the neuroscience lines from the two hospital systems came back and said, yes, we do believe that this will really help, and we're willing to put the finances there out on the table for this. We were also able to show them, and I think this is one of the reasons that they grabbed at this concept, was we were able to show them where they were going to save finances and FTEs in the hospital because of implementing a system like Pulsara was going to streamline the communication and the information gathering that has traditionally been done by somebody sitting behind a computer and with a phone and spending hours and hours a day on end gathering all this information for the service lines, and to say nothing about how they gather the information to then hand back to EMS, which we all know is extremely inefficient. And we could save all of that with Pulsara. We also had to have large conversations with the IT services in the hospitals. That ended up to be a very large portion of what the implementation was, to make sure that each IT system in the hospital was set up, was communicating, was not blocking Pulsara, etc. And again, our goal was to get all 4 of the major hospitals up online all on the same day. And so for EMS, the concept was a little bit easier to sell, although we still had the issue of several people or several agencies saying, no, we feel as though what we do is just perfectly fine. We don't need anybody to help us. And so that just general concept of change was something that we had to overcome. Also, there were some agencies that are not technical at all. They don't have smart devices. They would use flip phones. They weren't interested in using anything else except the radio, and so we needed to overcome that with the EMS agencies. As far as getting the EMS agencies started, once we past the concept of making this change, and they were able to acquire and figure out the rules of usage for the end user applications on smart devices. We were actually able to get all the core 19 EMS agencies in our city and surrounding area started all on the exact same day. And the training was so easy that it literally took 5 minutes to train somebody up on how to use this. I was expecting that there was going to be a lot of resistance, especially age resistance, meaning the older population of EMS providers were going to be very, very resistant to it. I call them the non-tweeting population, but actually it ended up that everybody embraced it very, very, very quickly. This just goes to show you, we started this in July of last year, and right out of the gates we had, and this was for STEMI activation, and this is a conglomerate number for 2 of the hospitals out there, where 88% right out of the gates, 88% of the STEMI activations made by EMS were made through Pulsara, and that was right out of the gates. Then we had a little bit of slump in August as we brought more of the EMS agencies on board, and people were really learning it. And then you can see that in September we shot right up to 100%, and it's remained ever since September between 99 and 100% of activations are made through Pulsara. You can also see here, this is CVA activations with Pulsara. In July we started with 75 and we went up to 88 and then 96. And some people may ask, why is it not 100% all the time? And we still do deal with some geography issues in Colorado, where if you're behind a mountain and you literally cannot communicate by wireless network, that you have to use repeaters off of the top of mountains to be able to get information to the hospitals. And so those activations, the very few of them would be done by radio, and then they would feed it into Pulsara as soon as they came into communication view. The benefits are tremendous that we've discovered so far. I kind of divided this out. The benefits on in the emergency department is that with the advent of Pulsara, we can get HIPAA compliant information on the patient and be able to pre-register them from the field so that we can have everything ready. We can save all that time when they get to the hospital. Doctors can already look up information on the patient's records. We can also monitor the patient's care, which we were never able to do before. Through Pulsara, we can find out what stage the EMS crew is at, and we can also monitor what's happening as far as the activations through these service lines in the hospital, because everybody reports in through Pulsara. So we know if there are people that have not communicated back, something that we would only find out later after the fact when things really went wrong before we started using Pulsara. One interesting thing that we were not expecting but has been a huge benefit is that we all understand from the hospital side that when a patient is called as an alert in the field, for instance, a stroke patient, we clear the CT scanner and we wait for the EMS crew to arrive. But sometimes there are hiccups, sometimes they don't arrive in that standard 5 minutes that's been reported. And what we're doing is we're essentially stopping flow in the emergency department so that in anticipation of somebody coming in that's going to need the scanner. Well, with the GPS on Pulsara, we can actually track where the crews are. And so we can time the exact clearance of the CT scanner or of teams or bothering physicians to look at certain aspects of the alert. We can time that down very, very, very specifically, and it saves a lot of ED flow and just interfacility flow, and that's something that we weren't anticipating that's been a great benefit. And then as you put all this together, you can see how by using the Pulsara, we're able to very systematically start the process of bypassing putting patients into emergency department rooms and putting them directly into the CT scanner or taking them directly to the cath lab. And so we're really starting to cut down on that. For the neurosciences, this is wonderful because we can actually transmit pictures that the neurologists can see in the field. And so they don't even need to wait to have the patient arrive at the hospital and to get that information from the ED doc. It also, as I mentioned, it improves the efficiency of use of the personnel and equipment, and then it improves the patient flow. And it has shown across the board to decrease time to CT scan and intervention. Here's a graph of two of the hospitals, and you can see about 3/4 to the right there's a green line that is vertical, and everything to the left of that line is pre-Pulsara. Everything past that line is post-Pulsara use, and then this is the mean door to CT scan time, and it's dropping precipitously as we're using Pulsara more and more and finding all the nuances of how we can use it. And so that is hard data that we can definitely show that's improving patient care. As far as interventional cardiology is concerned, one benefit is that because all of the information that comes through Pulsara right from the field goes all the way up the service lines, the interventionalists can see the EKG the second that the emergency department does, the second that anybody does, and they can, and they like getting that information. We can also, as I mentioned before, we can decrease the ED time or even bypass the emergency department in certain cases because the entire cath team and the interventionalists have already been activated. It was all done in that one seamless click of a button. So and one other thing is that the university has reported, and they just gave me these numbers yesterday, but they've reported that they have a 65% decrease in the amount of patients that are getting to the cath lab and getting wires placed, meaning that 65% of their patients are getting there faster than they were pre-Pulsara. And for the cardiovascular service to come back and say that is really amazing because they're the service line that typically felt as though they already had everything all squared away as far as communication was concerned. So if we go on to this next slide here where we talk about the benefits to EMS, and I'm sorry I accidentally put emergency departments here, but it's really the benefits to EMS is that it's minimal to no cost. And I say minimal because sometimes we had services that did need to buy smartphones that weren't using smartphones. But the end user applications for Pulsara, and as far as Pulsara is concerned, it's all free to the EMS agencies. It basically eradicated in one fell swoop any of the time discrepancies that we had between EMS agencies and the hospital times of alerts. We would always come back and kind of battle out, well, how long did it really take to get this person from the time that this was the STEMI alert was activated to the time they got intervention? We could never agree with EMS. EMS always had different times that they had alerted that the hospital was saying was different, and that affects the way that you report numbers. And with the advent of Pulsara, that just completely vaporized, and we don't deal with that issue anymore because everybody is on the same clock. The other thing that was amazing to me was that there was little to absolutely no resistance from EMS across the board. Rural agency, urban agency, volunteer, professional, it didn't matter. Everybody just immediately adapted to using the application because, in all honesty, it's modern. It's what we use anyway. And the big thing that we don't talk about often with Pulsara that I really want to emphasize here is that we get, as EMS, we can get immediate feedback on a patient. We're still working out some of the details, but what Pulsara will do is that as people log this information into their system in the hospital, and then they close the case, all of the information has been placed into Pulsara by everybody, including the interventionalists, and then that information is automatically fed straight back downstream to the front-end users, the curbside users, which are the EMS crews that brought the patients in. And so quickly are going away the days where we would have to have a EMS liaison spend all of their time figuring out what happened to a patient, if it was actually an appropriate alert, what was the intervention, how did the EMS crews do. That is completely getting taken care of by implementing this, by implementing Pulsara. And then obviously, to kind of close out my statements, is that who's the real benefit of this that we all really care about is the patient, because the patient simply gets faster and better care. Or I should say they get to the really good care faster, because we already feel as though we have good care, but they get there much faster, and ultimately with time being tissue, that is benefiting all of the patients. So where do we see that we're going with this? Because I can already see this planned out. We've actually had EMS crews that like the Pulsara system so much that they try to communicate through it without having an alert. Meaning when we first started the system, we just said we're going to start with the STEMI and we're going to start with the CVA. But the only thing that the EMS crews are supposed to be communicating through Pulsara are those types of alerts. But we have so many of the people out there in the field that have taken to this technology and basically said, no, I want to use this just to ask some general questions. I want to get this EKG to a doctor right now. I don't want to be relying on a fax machine and somebody having to look at the fax machine and me call in and say, hey, I'm sending you something. We have the doc look at it. They send in these EKGs, for instance, and they just say, hey, what do you think about this? Should we treat it this way? Should we treat it that way, etc.? And what we realized very quickly was this is EMS actually pushing to use what Pulsara has now implemented, which is their general alert, where we can alert the hospitals about any patient, ask any questions, give them any information. And so it's actually turned out wonderful, because instead of us having to go and say, okay, well now we're going to start the general application, we already have people that have figured out a way to use it without even being told that we're starting it. And so our next goal here in the next few months is to be completely up and running with the general application so that the EMS crews can transmit all patients, all information to the hospitals and not use the radio. The radio will still be there as a backup for the meantime, but our plan will be into the future that this would completely take away, kill the radio, and provide more modern-day communication. And so it has been an absolutely wonderful experience. It hasn't been without its challenges. Pulsara has been extremely helpful in working through all of the feedback that we've given them. We've handed them a bunch of quagmires that they take back and are figuring out the bugs so that it will fit our system, and it's just been wonderful. And we've definitely passed the tipping point. There is no moving backwards from this in our community. Everybody that moves in, we have a new hospital that just opened up, and it wasn't even a question. We basically said, you've got to start using Pulsara. Here it is. And so they're working on implementing, going through the process of implementing that. And we've just made it a community-wide system that we do believe is going to continue to raise the bar in patient care. And with that, I think I will fold up.
Well, fantastic. Well, thank you very much, Dr. Bronsky. So this is James Woodson again. So one of the things that I want to just really highlight is how much I personally enjoy talking to this group. I'm kind of part of this group. I've been in pre-hospital medicine and emergency services, emergency medicine for many years. One of the things that I really enjoy about this group the most is we're just wired different. If you basically go out into society and they hear a siren or see a bad event or something like that, most of society runs away from it. We're just wired differently. We hear tones, we hear a siren, we see something that needs to be addressed, and we're just wired that we run towards it. We don't run away and then just rubberneck. And so one of the things that I really want to compliment Dr. Bronsky and the Colorado Springs teams across the board is together we saw this problem. They saw Pulsara addressing this problem, and we've had the honor of really working with this amazing team there to really help roll up our sleeves and address the problem. When we look at the implications across healthcare, this is big. This is bigger than a lot of the other things that have a term crisis or epidemic behind them. And so we are full speed ahead trying to address this problem in a very comprehensive way. So for that, what I would like to do is answer a few questions.
Awesome. Thank you, James, and thank you, Stein, too. This has been a really educational presentation from both of you, and we've got a lot of questions already queued up from the audience that reflects that. One of the first things people have been asking about in the Q&A is money. What's the cost to the EMS system and to the ER, and how does Pulsara make your profit off of this product that does such good for the community?
That's a fantastic question. So, and I'm glad that was asked because a lot of this may not make sense, especially in healthcare, but this is a great business question. It's a go-to-market strategy question, more or less, which is a huge part of it. So if you look at modern platforms, they basically bring immense value to the platform before they start to monetize it. So what do I mean by that? There's a huge problem with solving a chicken and egg problem of how can you get this thing started in a region. The other thing is once it's started, if you're nickel and diming all partners, et cetera, you can't grow the platform quickly. And so what you do is you basically eliminate a lot of the complexity out of the system and bring immense value. So from a technology standpoint, a pre-hospital electronic notification is really the most simple thing that we do. That's the pre-hospital alert and receiving that at the hospital and a bidirectional communication there. But that brings immense value to the platform and allows us the opportunity to provide that instant feedback to EMS. The more complicated, both to install and to support, is the hospital component of it. That's also where the monetary value is, and so all pre-hospital communication currently is free, not just to EMS but to the hospital. But where we make money, which we have to make money or we can't provide this service, we have to be able to monetize it in some way or we can't keep the doors open. Where we make the money is basically selling the STEMI or stroke or other solutions within the platform to the hospitals. And so all the complexities that we were describing is very difficult to patch together that system. That's what we've solved for them, so there's significant value for them to pay for that. So that's how we make money in the system and keep the doors open.
All right, thanks for clearing that up. We've also got a lot of questions here just about integrating with the current systems that the EMS agencies already have in place, the EPCRs, things like that. How does Pulsara integrate with the platforms that are already being used in a system?
Perfect. There's a couple of answers. The first is exactly what it is that we're doing. So most of the stuff that we're doing is communication, and so we're replacing the oral tradition. So all the work and effort that you used to do to say something into vapor and it not get recorded anywhere, that's our focus is that initially. That being said, that does generate and convert communication into data. And so we are built in such a way that we can integrate with anything, really. So we're looking at the EPCR or pre-hospital EHRs, as well as on the hospital side, the electronic medical records on that end, as well as devices, and start to fill in the blanks, data repositories, all of those type of things. And so we're built in such a way that we can integrate with all of those. But as Stein was describing his system, as Dr. Bronsky was describing his system, you're 40-plus EMS agencies, 4 or 5 hospitals. How can you flip a switch when integration is required? And they each have a different system. That makes it where you can't spin up a system instantly within a region. And if the integration breaks down, what happens to the system? Does your critical care communications break down? So we built with a philosophy of it has to have instant value out of the box. Integrations are a value add. We are currently working with and talking to various entities about integrations, not just with the pre-hospital systems, but with the hospital systems as well.
All right. And where does the data live? Is it cloud-based? Do we have to have massive server investments? What's going on there?
Yes. So this is a cloud SaaS platform. So the data is stored in the cloud. Our customers have 24/7, 365 to that data. It's their data. So they have full access to it. There's no additional hardware costs or anything like that. So basically, you just need access to the internet, a web browser, and your secured login credentials.
All right, that transitions me actually really nicely into this next question. One of the common complaints that we're hearing kind of out in the field is all of the different logins for these different accounts that providers have to have, and remembering a different password for whatever kind of platform you're logging into. Does Pulsara have any kind of single sign-on solution to mitigate that?
Yeah, great question. So it's also the number one question our client support customer service gets as well. The number one thing is forgetting your username and passwords when you have so many out there. So for those of you that don't know what single sign-on, there's various other versions of it as well. That's basically where your organization can have a single login for all of their approved applications. So that is something that we have an integration point for. We can do that. We have not done it yet, but that is something that is known and we're actively working towards.
All right, great. Next question, are staff supposed to use their own phones, or is a new purchase of phones for every provider required? What kind of devices are we actually talking about when we're implementing Pulsara?
I can answer some of that because in Colorado Springs area, we dealt with all sorts of combinations of possibilities for that. You can use any of the standard smart devices out there. What we ended up landing on was that our EMS agencies did not want people having this information about patients on their personal phones. even though it's very easily usable and it is HIPAA compliant. We just chose as a community not to do that, so we actually use company phones for everybody, and they're handed that phone when they go out for the day.
Yeah, that's a great answer, Dr. Bronsky. That is much more specific, et cetera, than some of the answers that I can provide as well, because it's true boots on the ground how you solve that problem. I'll say one other thing kind of a different way as well, which is on the EMS side, they can actually use a web browser version, so they can use their Toughbook or whatever. If it has Chrome or Safari, they can use a Toughbook, so there's no mobile technology devices. On the EMS side as well, they can use a bring your own device. It is fully HIPAA compliant. Nothing is stored on the device, so there'd never be a reason for a court to subpoena it, or you need to remote wipe it, because literally nothing's stored on the device. Or the third option is it's a provided device. So those are the three options they have on the pre-hospital end. The platform is designed to leverage a bring your own device policy, but as healthcare is evolving and trying to adopt mobile technology, there's the answer of the way that it's actually built versus the way that your system will tolerate it. And Dr. Bronsky gave a great example of how he operationalized it in his system.
All right, great, thank you. Next question, is Pulsara currently available in all states?
So it is currently available in all states. We have contracts in 13 states currently, and Australia. So that's where we're actually implemented, but it is available everywhere.
All right, thank you. And we've got some other specific questions about people wanting to know the process, how to input data, or asking, specific cost estimates for their system. Those are questions that, James, I understand you and your team will be able to answer offline. So if we don't get to your question today in this Q&A session, stay tuned for an email from Pulsara. They'll be following up with you to answer those specific questions for you guys. Next, I'm going to jump to this question. How much time does it take the ED to enter all of the information into Pulsara so that it's not redundant with the other documentation systems that they already have?
Well, from our experience, when the information comes from the field, there is practically nothing for the emergency department to do. The emergency department is one link in the chain of where this information is delivered, and they get the same information as for instance, the cardiac cath team does, as the interventionalist, and so they literally have to press an acknowledgement button that says, yes, we got the alert, we're here, we're part of the chain, we're waiting for you to come. And so all the information has already been put in from the field. They can add some things along the way if they would like, but it takes no work at all. Where the work does come for an emergency department is that are the patients that are walk-ins, because we've been concentrating on talking about EMS in this, but when a hospital fully integrates Pulsara, they now use it as their communication system, not just from EMS, but their communication system for any stroke or any STEMI that will walk through the doorway. And so if they do come through the triage area, then a nurse or a tech or somebody has to be assigned to be able to feed in that information that EMS would feed in. And it takes about, I would say, a minute to feed the information in.
I will echo what Dr. Bronsky is saying as well. So there's two components. One is starting a case. When you're first starting to activate a case and getting familiar with Pulsara and you're not using it every day, it takes about 50 to 60 seconds to start a case. Once you get familiar with it, if you watch me activate a case, you watch people that have been using it on a daily basis, especially general patient will help that, where the medics are truly using it every day. A lot of these cases you can get down to 30 seconds very quickly. After that, every single team member, they typically only have 1 or 2 buttons they need to push. And so when you see the demo video and watch that, there's a lot of buttons flying around. But when you divide it up to my job, I used to have to pick up a phone and make these phone calls and sit on hold and keep ringing and all that stuff. I can now literally do it with 1 tap. That takes me a second. And so when you divide up the jobs among all the team members, everybody has 1 or 2 taps they need to do, is the way a typical system is designed. A really fun thing to do when we come to your site, which we're happy to do. If you guys have questions and want to know what it would look like in your system, we can come to your site, do a demo and walk through and that kind of stuff. A fun exercise, honestly, is to sit around and have them describe their system and write on a board how long it takes them to do just that communication piece. And then they get their turn with the Pulsara app and they hit 1 button. They're like, oh my goodness, this saves a ton of time. So this is communication, not the documentation. The data that we collect will merge over time with our data documentation systems. But right now, the key thing, the problem that we're trying to solve is this communication crisis that we're talking about. And we do that in a very cost-effective and time-effective way.
All right. Thank you, James, and thank you, Stein, again so much for this great presentation. And also thank you to Pulsara for sponsoring the webcast and making this presentation available for our viewers. Don't forget, if you're watching the presentation still, we will be archiving this webcast at jems.com/webcasts. That will be live within about 48 hours, and you can download a PDF of the presentation and come back and listen to it again and again for all of your information needs. Thank you so much, everyone, for attending. And like I said, we'll be answering some questions offline, too, if you had those more specific questions for James and Stein. Thank you again. We hope to see you next time for a JEMS webcast. Thanks, everyone.
Healthcare has been communicating the same way for decades. Pulsara simplifies that. It's about time.